about interpretation of lipid profiles and optimizing lipid management. Um, my name is Dr. Rani Khatib. I'm a consultant pharmacist in cardiology and cardiovascular research and a national clinical champion for lipid optimization. And it's my pleasure to have my colleague with me, Dr. Stewart Pattman, who is a consultant chemical pathologist from Northumbria Healthcare NHS Foundation Trust. The idea behind this session is I'll present some slides and explain the concept. I've got a few cases to share with you, but I will probably bring in my colleague, Dr. Stewart, to comment or make any suggestions. I can't see the screen when I'm presenting, so I probably will need some of you to speak up if there is anything that you wanna say. Or Jess, maybe you can just alert me if there is anything I need to be aware of, because I've got a shared screen in front of me without any anything that I can see from Teams. These are the objectives for today. We're going to talk about the blood tests to request for lipid optimization. Why do we request them? Which one should we request? Why do we need them? What targets we should be aiming for lipid optimization, and what to do if anything is abnormal. And we're going to look at a couple of case studies just to discuss with that for that effect. Right. So let's start. So the first thing to remember is that the national lipid pathway, it actually summarizes the management of lipids overall. It's a double-sided A4 sheet. I know it's quite packed, but actually you don't need to read every single box in this pathway whenever you want to use it. I'd say do it once so that you're familiar where you are at when you're using the pathway. But what is most important that people tend to miss is the first box here that you have, which is the initial consideration. And the initial consideration is highlights for you the importance of actually having a full lipid profile when you're assessing lipids, and not just total cholesterol. And the reason for that we'll elaborate on later on. So the first thing you need to remember is that when you're trying to optimize or manage lipids, you need a full lipid profile. It doesn't have to be fasting. So it's a non-fasting full lipid profile to start with is important. And also you need to know HbA1c to assess if patient has got diabetes or well-controlled, poorly controlled diabetes. These are important initial assessment baseline in order to plan what intervention the patient needs in terms of therapy and in terms of further interventions. Then you need to delve into secondary causes of hyperlipidemia, which will highlight some of them alongside Stuart, who will talk about some of that. And then you want to make sure that there is a follow-up. You don't fire and forget. You do baseline, and you want to assess whatever intervention that you did, they made a difference. It's important to know also patients' triglycerides, starting with a non-fasting triglycerides, then later on can do a fasting one. We'll talk about that later on. And it's important to remember the 4.5 cutoff point, because you will notice that if somebody's got triglycerides more than 4.5, most labs will not report any LDL calculated back to you because of what we'll explain later on. So this kind of amount of things that you need to be thinking about, I'll elaborate about them as we go along. But feel free to put any questions in the chat as we go along as well. So the first thing to remember is that the lipid profile, or the lipids or the lipoprotein, are quite complex. And as you can see here from this picture, no means I want you to remember everything in here, but I wanted you to see that we've got different lipoproteins with which include within them, of course, cholesterol and triglycerides. And generally, when we are trying to measure cholesterol, if you just measure total cholesterol, you are measuring too many components there. As you can see from this equation, you're measuring VLDL cholesterol, IDL cholesterol, LDL cholesterol, LP little a, HDL. You're measuring so many things, and this is not helpful in trying to identify what you're focused on. So if we're treating somebody because they've got high levels of LDL, ordering total total cholesterol itself doesn't tell us if the LDL is high or low, because the LDL could be the contributing factor to total cholesterol being high, but it could be also the triglycerides. So that is not sufficient. That's why we have other components and other calculations. We talk about non-HDL cholesterol because we usually consider HDL cholesterol to be not associated with atherosclerosis, usually at certain level, up to a certain level, and for that reason we report non-HDL cholesterol. Non-HDL cholesterol is basically total cholesterol minus HDL cholesterol. That's what it is. It's just the calculations that we do, and it is usually uh, the ApoB lipoproteins, which is on this side here, that tend to be more cause of atherosclerosis. So LDL is only one component of that can lead to atherosclerosis, but you've got other components such as LP little a that we don't routinely measure in daily practice. So in daily practice, when you order a full lipid profile, ideally what you're getting what the total cholesterol is, what your HDL cholesterol is, what your triglycerides are, and what your calculated LDL cholesterol. So very important to remember that labs don't report usually direct measurement of LDL cholesterol. They report calculated LDL cholesterol. So they rely on an equation, which I'll elaborate in a second. And this equation has a requirement, which I will elaborate on later on. But very important to have a full lipid profile to understand the overall picture before you start making interventions. The equation that is widely used at the moment in many of the labs across the country is the Friedewald equation. And the equation goes like this: is LDL cholesterol equals total cholesterol minus HDL cholesterol minus triglycerides divided by 5. And this equation, when it was validated, it was validated in a fasting population. For that reason, when we want an accurate reading of LDL cholesterol, we recommend that is done on a fasting sample so that the equation can give you a bit more reliable LDL cholesterol calculation. But this equation doesn't work if your triglycerides are more than 4.5. It simply will not report what LDL cholesterol is. So if you order a full lipid profile and your patient has triglycerides more than 4.5, the LDL cholesterol will come as blank. And the reason is because the equation can't apply. Now, if the triglycerides are less than 4.5 or less, you'll get a number for LDL cholesterol. It probably be an underestimation of LDL cholesterol, but at least you'll get some form of calculation so that you can have an idea overall of what you're dealing with. There's a new equation that is being recommended at the moment for use, and we've mentioned it in the National Lipid Pathway, which is the Samson equation, which can calculate triglycerides up to 9. So it gives you a little bit more leeway, if you like, if somebody's triglycerides are a bit high, to get some kind of an idea what their LDL cholesterol is. Not many labs are using it. We are in Leeds looking into incorporating it into our calculations, but hasn't been done yet. So these are the main things you need to remember, and this is why we are so worried about the fasting and non-fasting. To start with, you don't need a fasting sample. The fasting sample is mainly needed if you want a very accurate LDL cholesterol, and also a fasting sample is needed if your triglycerides are too high and you want to make sure that one component triglycerides, which is the chylomicrons, are excluded, because these are the ones that tend to go higher if you are not fasting. And for that reason, if your patient has got high triglycerides, it would be a good idea to repeat it in a fasting sample just to make sure that it isn't just what they've eaten last night or just before they had the test, that it is something that needs an intervention. And we'll talk about that later on. Now, another thing that the pathway is talking about is excluding secondary causes of hyperlipidemia. There are too many causes. I'm not going to go through all of them. The most two important that are can be excluded easily when you see your patient, and I highly recommend them, is number one is the thyroid function. whenever you assess your patient for hyperlipidemia, always assess the thyroid function, because if patients do have hypothyroidism, they're likely to have elevated triglycerides, but more so cholesterol. And therefore the readings won't be true reflection of what actually we are managing here, because if you correct their hypothyroidism, then their lipid profile will get better. So it's very important when you're assessing your patients for hyperlipidemia, you assess that the thyroid function is sound, is normal. They haven't got hypo or hyperthyroidism, because that could affect your lipid profile. The second thing which is important in assessing your patient hyperlipidemia or lipid profile is to do a HbA1c. And the reason we do that, in order to exclude diabetes, but also if your patient diabetes is not well controlled and HbA1c is elevated, you're likely to have high triglycerides. And it is not uncommon that we get referrals of patients who are actually either with poorly controlled diabetes, or patients who newly diagnosed diabetes, triglycerides all over the place, simply because their HbA1c is too high and needs managing. And these are graphs just showing how blood glucose levels do affect level triglycerides, and also have some effect on your LDL cholesterol. Other causes that we don't tend to see a lot is a condition called nephrotic syndrome, where patients usually will display. I had probably 2 patients that I've seen in my practice with nephrotic syndrome, and usually those are patients who need managing their underlying secondary cause of hyperlipidemia. They tend to have high level of proteinuria, and that's why we need to do urine ACR on those patients in order to exclude nephrotic syndrome. But they tend to present sometimes also with edema, and that needs to be, and fluid retention, that usually needs to be managed. But that's kind of another thing that you need to be aware of. Stuart, I know you wanted to comment on that. If you wanted to chip in anything about the secondary causes of hyperlipidemia, please chip in based on your practice. Yeah.
No, thanks, Rani. I think it's very important to, as you said, cover some of these tests: thyroid function, HbA1c. We're mentioning liver function as well. Not only as to rule something out, because what you don't want to do is start treating something, jump into treating with statins or what have you, when actually you've got something which is driving the hypercholesterolemia. Interestingly, I often get asked around the hypothyroidism, what level of thyroid, level of TSH, say, would explain a high cholesterol, and there's no direct correlation with this, but usually what you find is someone who has been hypothyroid for a longer period of time would tend to have a higher cholesterol level. And for those patients, you really do want to make sure you are addressing the hypothyroidism, because the other issue is, if you've got a hypothyroid patient and you start them on a statin, there is some evidence to say they could have a higher risk of side effects when they're commencing a statin as well. So there's lots of good reasons to screen these patients and make sure that we're not missing anything at baseline. Thanks, Rani.
Yeah. And it says headphones.
Thank you. Thanks, Stuart. Is that a question from somebody, or is that just a mic on by mistake? All right.
Rani, can I just ask something? Sorry, we've got a question in the chat. Do
Yes.
PPIs increase cholesterol?
Proton pump inhibitors.
Mm-hmm.
Yeah, well, to be honest, I don't usually, I haven't, there might be part of the listed drugs that potentially can affect your lipid profile. It's not something that I screen for, to be honest with you. I don't know if you've got any experience with that, Stuart, but it's not something that I usually have on my radar.
Yeah, I think that there's some talk about whether PPIs may interfere with cholesterol metabolism and and possibly statin action, but actually for cholesterol itself, it's not something I would be looking for. Obviously, there's other drugs, atypical antipsychotics, steroids. You've got a few on the list there, I think lower down as well, that are ones that do. But PPRs are pretty prevalent actually in terms of patients, the patient group you might be looking at, but it's not one that I would put down as a cause of raised cholesterol. Thanks,
Stuart. Sorry, somebody's putting there more questions about hypothyroidism. So I've got a patient who have hypothyroidism but are treated with levothyroxine. Should they be cautiously initiated on statins for secondary prevention post ACS? I guess, as Stuart said, I'll get Stuart to say what he thinks. But I usually what we would say, I would initiate a statin. I probably would monitor closely. I probably would want to control the hypothyroidism and treat it. But post ACS in specific is because we are trying to get the multiple benefits we've seen from high doses statins, I guess, which is beyond just cholesterol lowering. It's probably a different scenario that somebody with stable coronary disease. So post ACS in specific, it depends what cautiously means. I wouldn't withhold it, or probably would correct hypothyroidism, but withhold it. I don't know what you think, Stuart.
Yeah, Rani, I think if they're post ACS, I would get on with the statin treatment. I think the question here says if the patient have hypothyroidism but are treated with levothyroxine. So it kind of depends on if they have got a TSH that's still elevated. Generally, if they're post ACS, they've got more benefits to be gained from starting the statin. I would probably just if the TSH was still slightly raised, I would obviously potentially be I guess carefully adjusting the thyroxine. I guess in someone who may have cardiovascular disease, you don't want to give them obviously too much the thyroxine. But I wouldn't be holding back the statin. I would be going for atorvastatin 80 milligrams, and I would at the same time be saying, right, do we need to titrate up your thyroxine? Also telling the patient, as you would do any patient initiating on statins, you say if you get if you get side effects, and obviously these are things to be aware of, and flag up if you do get any significant myopathies.
Thanks, Stuart. Just back to carry on with the the presentation. Otherwise, I'll come back to these questions later on. So just carrying on. Sorry, let me just get. At the back of the pathway, there's a lot of good boxes there about monitoring, and also there's a box on the right, as you can see, about triglycerides. I do urge you to read them, even at least once, familiarize yourself with these boxes. The idea behind it that they are a summary to guide you through the different monitoring parts. I've highlighted the triglycerides because I know we get a lot of questions about that. Generally speaking, the issue with triglycerides is that when you have a non-fasting triglycerides, it can be affected by multiple things, especially what you've eaten, but also alcohol ingestion and you drank. And for that reason, you can get fluctuation triglycerides, not like you'd have for LDL, for example. And the reason we are too focused on triglycerides is because if it's too high, you can't measure the LDL cholesterol, but also above certain levels, we'll start worrying about the consequences of triglycerides in terms of pancreatitis. And generally speaking, this is the box we have at the back of the guidance where it says, if you've got somebody with these different levels of triglycerides, if they are 4.5 to 9.9, and the non-fasting triglycerides is more than 4.5, then repeat a fasting one. And the reason you're repeating a fasting one is just to exclude that this wasn't just a one-off high triglyceride reading because of what they've eaten and what they drank the night before. And if it shows persistence, then we need to deal with it. And you just need to be aware that the CVD risk may be underestimated in patients who also have high triglycerides, because there is some evidence of association between high triglycerides and cardiovascular disease. Now, in this specific population, you repeat it, and if it's persistently high, then you may want to think about what we're going to do. You need to seek advice probably if non-HDL cholesterol is more than 7.5, just to exclude mixed hyperlipidemia and also high triacylidemia as well. Now, if you're hitting more than 10 or more than 20, then we becoming really worried here about acute pancreatitis. And it is then where we tend to seek advice from the lipid clinic. And the reason usually is to initiate those patients on additional therapies beyond just the statin ezetimibe. Important to remember that statins and ezetimibe do reduce your triglycerides, but not to a great extent, but they do reduce them. And the other lipid lowering therapies, such as bempedoic acid, such as inclisiran, such as PCSK9 inhibitors, do not usually affect your triglycerides. So once you put somebody on statins and ezetimibe, you're likely to get some reduction of triglycerides. But if somebody is hitting very high levels of triglycerides, then we need further intervention. It is then when phenofibrates and high doses of omega-3 might be used to reduce that. The only scenario that we have there for the use of ecosapient ethyl in line with the TA805 is in patients who are have established cardiovascular disease and they have well-controlled LDL. If their triglycerides are above, are 1.7 or above, then you've got the option of use ecosapient ethyl for that. But usually the licensed doses are not for managing, those very high levels of triglycerides of more than 10, more than 20. You probably need higher doses to control it, and other drugs. So I'd say if you've got a patient who are hitting the risk of pancreatitis levels, which are more than 10, more than 20, then you probably better seek advice. So this is where the triglycerides element lies. I don't know if you want to add anything, Stuart, on that.
No, I think we so my practice would be that that those patients are generally safety netted in terms of we would as a lab put advice around the risk of acute pancreatitis, which is not it's still small, but obviously these patients need to be aware should they get the should they get unexpected abdominal pain. There's also things we can do with regards to intervention about advice to these patients as well. And then there's more specialist investigation these patients may need to understand why their values are persistently high. I think there was a question there just about when can you repeat fasting triglycerides as well. So I mean, essentially, a period of fasting is 12 hours overnight. Fasting, I tend to quiz the patients and say, look, is there anything about your your lifestyle, your diet that you may want to change and intervene, and you probably then need a couple of weeks at least for patients to make changes. Technically, you could do it the next day after a 12-hour fast, but if there's things around that the patient wants to start to intervene, then you don't want to do it that soon. You want to give them a chance to make some changes, cut down alcohol, whatever that they're doing, to see if that has an effect. But technically, you could do it the next day if it was a 12-hour fasting period overnight.
Thank you. So I'm just conscious that the sharing stopped. So just continuing with that, then the next thing that people tend to ask a lot about are targets. So we know historically that NICE talked about 40%, more than 40% reduction on HDL cholesterol. That is the target that NICE has recommended. I know they're debating and updating their guidance, and that is going to come in December this year. But we know that the QOF has chosen the less than 1.8 LDL cholesterol, less than 2.5 non-HDL cholesterol as a target to aim for secondary prevention. It didn't. The QOF doesn't say anything about primary prevention. NICE says more than 40% reduction on HDL cholesterol for both primary and secondary prevention. So the target, according to NICE, for both primary and secondary prevention is more than 40% reduction of non-HDL cholesterol. Now, you'll notice in the lipid pathway, national lipid pathway, we have chosen the JPS3 target, which is less than 1.8 for LDL cholesterol, less than 2.5 non-HDL cholesterol. For FH, we tend to go for more, we tend to have a bit more aggressive, and NICE actually specifically recommends 50% or more reduction in LDL cholesterol, at least on non-HDL cholesterol. So FH is different. But I guess the numbers to remember is you need more than 40% reduction in non-HDL cholesterol, and if you want to convert that in a more up-to-date kind of targets, think about LDL less than 1.8, non-HDL cholesterol less than 2.5. And then on the left here, what you see is the ESC guidelines. And the ESC guidelines which I'll talk about a little bit more, is what many clinicians seems to use as an additional element. So let me just highlight what this says. First of all, the way ESC works, it says patients' risk of having cardiovascular disease can be divided into 4 categories: low risk, moderate risk, high risk, very high risk. To be honest, in the UK, the low and moderate risk are not really there in most patients, because if you look at the definition there for ESC, it defines a patient to be at high risk if their score is equivalent to Q risk, if their Q risk is 5 or above. So if somebody's Q risk, that's primary prevention. If somebody's Q risk is 5 and above, according to ESC, they are high risk, and therefore their LDL target is 1.8. Anybody who's got atherosclerotic cardiovascular disease, whether it is clinical or imaging, according to ESC, they're very high risk, and therefore their LDL target is less than 1.4. What is important not to forget here is that this is not just the definition of a target according to ESC. If you look at the far left there, you've got and 50% or more reduction from baseline. So ESC is saying you need to have at least 50% reduction of LDL cholesterol from baseline and aim for an LDL cholesterol less than 1.8 or less than 1.4. So the 50% or more reduction in baseline is pretty much what NICE said, but about non-HDL cholesterol. But anyway, so I think the numbers you need to remember in terms of target: aim for less than 1.8 at probably would be a good target to aim for LDL cholesterol, or less than 2.5 non-HDL cholesterol. 50% or more reduction from baseline would be a good idea. So that's kind of targets in general. Now, it's important then when you're treating somebody to keep that in mind in terms of combination therapy, because if you know that somebody's LDL cholesterol, let's say, is 5, and they've had acute coronary syndrome, and you need to bring it down to less than 1.8, it's highly unlikely that they're going to get that by just giving them a statin. So you need to have a little bit of a think of what combination therapy they're going to need, probably to bring down that that level of LDL cholesterol to target that we're aiming for, or the extent of level reduction that we're aiming for. So that's probably the newer way of thinking, and there's a lot of studies coming now showing that in some patients probably we don't just give them atorvastatin 80 milligrams, but we give them atorvastatin 80 milligrams and ezetimibe together after acute coronary syndrome, not just to lower the cholesterol in general, but also to try and get it as close to the target as possible. So there are more and more studies now trying to advocate combination therapy in order to get us closer to targets that we're aiming for, that we need to keep in mind. We get asked a lot about time to response. How long does it take to see a full response from these different drugs? When you give somebody statins, you're probably going to start seeing some benefit within a week, but you probably need at least 4 weeks of full adherence to start getting maximum LDL reduction. Ezetimibe, same thing. You can start within a week. Maximum effect, probably 2 to 4 weeks. Bempedoic acid, probably 4 weeks. PCSK9 inhibitors, probably about, we look about 4 weeks, but we tend to go for 8 to 12 weeks in the guidelines, simply because by the time you initiate, by the time a patient kind of misses a dose, starts a dose, we just want to make sure that enough time has lapsed that the patient got the best out of their therapy. We know that there was an issue about repeating it, and I know ESC guidelines trying to say probably measure it within 8 weeks. Our national guidance says within about 3 months, after 3 months, and the reason is because of this. And the inclisiran question is slightly different because the administration is slightly different, but usually near maximum effect you get from inclisiran within about 90 days of treatment. I hope that gives you a bit of an idea. I'm not sure if there are any questions, sorry, in the chat about anything.
Rani, there was one just there about time to be taking a statin. So obviously you make most of your cholesterol in your body when you're at night time, when you're asleep, and the the statin, well, the more traditional statin half-life, so like simvastatin and atorvastatin, are shorter. So last thing at night is usually the traditional time that we advise patients to take that. Brush your teeth, take your statin, go to bed, and then it basically hopefully gets them in a pattern of doing that. There are some, so at nighttime, that's why I advise the patients to take it. There are some like rosuvastatin that does have a longer half-life, and when we get some patients where we're having difficulty managing the patients, we sometimes even use things like intermittent dosing, so not daily dosing but intermittent dosing of rosuvastatin. That's the only one I use intermittently because it has a longer half-life and you can get away with taking that at slightly different times. But I think generally if the patient can take it at night when they go to bed, that's the time to take it because it makes more sense in terms of your synthesis of endogenous cholesterol.
So I agree with that, Stuart. In our clinic, though, we do measure adherence routinely, and statins are the most forgotten secondary prevention medicines. And usually we find that many patients forget it because it's at night. And I think on balance of things, if your patient seems to forget it at night, taking it is better than missing it. So I would say take it at any time, especially because nowadays we're prescribing atorvastatin, rosuvastatin, and because they're long acting, as Stuart said, I would probably say take it at any time that is actually works for you so that you don't forget it. So many of my patients, I'd say, because some patients, all the medicines are once in the morning, I say if you prefer to take it in the morning or lunchtime, and if that works for you, and usually, you know, the statin is the only one lurking in the evening to take, I don't have an issue with it taking it, because probably you'll get way more benefits from having it than missing it. So I now just say take it whenever it works for you and makes you take it more, because we want that sustained benefit. Sorry, the NICE algorithm mentions to check timing of dose taken. Okay, yeah, we talked about that. Silly question, but I'll ask anyway. Does it make a difference if a patient is on night shift? Yeah, it does. I've had this question once before. So what happens, your biological clock, your chronological does change, but it takes about 3 days. So if you've done one night shift, is not enough. So for the metabolism of your cholesterol to change, you need to have change your circadian cycle for at least continuously for at least 3 to 4 days for this to change. It's not a silly question, it's a good question. I had this question in my clinic. But you need to remember to put it back again, it probably requires you also about 3 to 4 days. That's if you've done it continuously, but a one-off night shift does not change your metabolism. But if you work 3 consecutive or 4 nights, then your circadian cycle does shift, and therefore your body seems to think day about night and night about day, and therefore in these cases I would change it. But if it's just a one-off night shift, no, carry on as normal. But if you're working a whole week night shifts, then yes, change it. Your day becomes night and your night becomes day. Right, let's just go back. Sorry, just keep kind of coming in and out of this. So the other thing that we I'm just going to share again. Sorry, just bear with me. The other thing that we tend to be asked about is CK levels. So generally speaking, we say we do not measure creatine kinase if a person asymptomatic. We tend to measure it if the patient have persistent generalized unexplained muscle pain, or we're suspecting some statin toxicity, then we measure it. It's very important, though, that when you measure it, you don't jump quickly to think that any elevation of CK indicates there's a problem, because CK levels can be elevated for many reasons. And I do commonly get referrals from GPs where say this patient's CK has been elevated, I stop the statins, and it's usually is only 200 or 300, and that's I need to remember that CK levels can go up just by you going to the gym, because CK levels do get elevated from any kind of exercise or use of muscles that you can have. So not every CK elevation is important. For that reason, the statin tolerance pathway, it does tell you a little bit more about it. It says, for example, if there is clinical concern, or CK levels are 4 times the upper level, the upper range of the CK levels, then you consider stopping it. Of course, alarm bells should go if it's more than 10 times the upper level, because you start worrying about more toxicity, worrying about rhabdomyolysis, etc. If it goes 50 times, then it's kind of most likely rhabdomyolysis. But what I mean is, CK levels is a good guide when there is potential muscle pain and symptoms that patient is reporting. But not any level should scare you. You start worrying when it's about 4 times the upper level. There's a nice table at the back of the statin tolerance pathway which discusses this in detail, so I urge you to have a look at it. But the general rule is that we don't measure CK if a patient is asymptomatic, according to NICE. Is there anything you want to add on this, Stuart?
No, I mean, I think that the one other thing that ties in nicely with the hypothyroidism, that hypothyroidism can give you high CKs as well. So I think it's always a difficult one in terms of, as soon as you're a blood test, you're potentially opening a lot of questions. So before you request that blood test, you need to have a question, and that's where that approach of saying you've got unexplained muscle pain, so making sure that you've checked, I guess, things like your vitamin D, if they've not got anything like polymyalgia rheumatica or concurrent infection or things like that. So I know a lot of people do have muscle aches as well, or aches and pains. So it's just pulling apart and teasing apart, is this is this a new thing? Is it, the severity of it, etc. I think there's a question there in the chat just about, should we check CK in patients with high alcohol intake prior to initiating a statin? They don't wish to change their drinking habits. Would we ever check prior to starting a statin? So I think my answer to that would be no, on the basis of if they just had high alcohol intake. Obviously, alcohol could be a driver of their raised cholesterol as well. So you would need to, or you'd want to address that with them as well, and seeing what the propensity for they are to change. But in terms of a CK on the basis of linking with the alcohol, then no would be my appraisal of that.
Thanks, Stuart. So I can't see the question, so please alert me if there's any that I'm missing. Sorry. So let's just carry on. So I have 2 cases to share with you here. These are real cases that we have from my clinic. So this is a referral I had of 65 years old male, who, as I asked, this patient was basically reviewed in a cardiology clinic, and basically they referred him to me because they thought they might have FH. And the background of this patient, he had a STEMI and had primary PCI, and basically his cholesterol readings were total cholesterol 10.7, triglycerides were 9.8, and he has some residual disease in his LAD, etc. And they've already started him on atorvastatin and commenced him on ezetimibe as well, and they wanted him to be reviewed and referred to genetic testing if he's got FH. So this is the case. So I've seen this patient. The first thing we do when patients come to us, we do a lot of blood tests. So this patient has got diabetes, and we have always something that we do is that we check this patient's HbA1c when they come to clinic, just to see how well their diabetes is controlled or not. That was the plan. These are the drugs that the patient was on, standard secondary prevention, but he was on insulin. And most of the readings we had were prior to come to clinic. So what we did, we actually took a full lipid profile, did HbA1c, did thyroid. This is the kind of things we do as a standard when patient comes to us to clinic. And lo and behold, this patient's HbA1c was 148 when he came to clinic, and thyroid function, everything else was fine. And in this case, what we did, because his HbA1c was very high, we couldn't measure his LDL cholesterol, and he was already on atorvastatin and ezetimibe, but we really wanted to know what's his LDL cholesterol. Of course, when we did this, you remember what we said about the Friedewald equation, that if triglycerides more than 4.5, we can't calculate LDL cholesterol. So what we did, we sent a sample for beta quantification, which is something that you can't do generally in primary care, something usually that needs to be done by the lipid clinic when it's a little bit more expensive test, where it actually measures the LDL levels. And surprise, surprise, this patient actually had an LDL of 0.59. So this patient did not have any, evidence of FH whatsoever. All kind of family history wasn't there. He did not actually need to be. All what he needed is better control of his diabetes. And when his diabetes is better controlled, basically his triglycerides came down nicely. And when we kind of seen him again, and his triglycerides were 6.4 after his HbA1c was much better controlled at 60 instead of 148. But you can see there that LDL was not an issue. So this patient was referred to us for FH, suspecting FH. But in actual fact, what was missed is that he had poorly controlled diabetes. Better controlled diabetes seems to have improved his triglycerides. And when we actually did his LDL directly with beta quantifications, we found that his LDL cholesterol is very well controlled. So this is something that we do get, and that's why we always say, when you do check patient, assess them for lipid profile, do number one, full lipid profile, but also remember to check if they've got diabetes or thyroid disease, if it's well controlled or not, because that does impact your lipid management. So that's case number one. I'll just see if anybody's asking any questions there. Is there any questions that I missed?
I think there's one just about that diet in terms of what is best, what you should target more, the saturated fats or the carbs. It's a classic one. I think that it's a kind of, in general, both I've said, but both aren't good. I think it depends. If you've got high triglycerides, you might want to, it might be the refined carbohydrates. You might be addressing it. Probably depends a bit on the individual as well. I mean, there is a resource there, Shared Heart UK. I've got a quite good sort of traffic light system around some of the different diet things. And there's a question there about behaviors. I think this is always a very difficult one. If people have got uncontrolled diabetes and they don't want to improve it, then it really is that they're missing the point. You know, you can throw statins at people, but you know, you really, as that case is illustrated, you really need to address that the HbA1c is going to have probably the short-term biggest risk on the individual, rather than obviously the cholesterol there.
Thank you so much. Just moving on to case 2. So case 2, let me just share. So case 2 was a 56 years old female who was referred for better optimization of lipids due to query, probably non-adherence, something else going on. She came to see us in clinic. She was well, blood pressure reasonably controlled. She weighed 93 kilos. She displayed symptoms of tiredness and weight gain. Basically, this lady's she displayed a bit of a strange response to, she was prescribed atorvastatin by her GP and increased to 80 milligrams and still not responding. And her LDL seems to be persistently high at 4.1. And in clinic, when she came to see us, she had an LDL of 4.6. She got us worried about family history, FH, but she had no family history. FH was excluded. But what was interesting is that when we've done her thyroid function, she had a TSH of 9.5, and it was clear that this lady had hypothyroidism, especially that she was talking about tiredness, weight gain in previous months. So probably that's why her cholesterol wasn't responding as well to the statins that we're given. And this is not the first patient that we see in clinic. We get many patients when their thyroid function is playing, the response to lipid lowering therapy is haphazard, and usually the first thing that patients get kind of thought to be non-adherent, which is sound, and in many cases is the case that patient non-adherent, but always be suspicious if you've got something that doesn't tally when you introduce a statin, for example, or lipid lowering therapy in a patient and their cholesterol doesn't seem to respond, suspect that something else is causing it. And indeed, we have sent her for treatment, and her GP managed her. She was started in levothyroxine, and she came to see us months later just to check on how she's getting on. Her TSH was have normalized. She feels much better. She actually lost weight when she came to see us. So maybe it's a combination of statins working, thyroid being corrected, and losing a bit of weight. This was a bit of a primary prevention. We did actually give her choice to whether she wants to go on a statin or not, and she seemed to be happy. She didn't have any side effects, so she wanted to carry on, really. I think she had a bit of a kind of worry about cardiovascular disease because she had friends who had them, so she wanted extra protection. So we just settled for that and left her to it. So this is just another case that we're thinking. Is there any questions in the chat, or shall I continue?
Yeah, did just one about, I think it's related, it's about when to check statin response to statins. So I think 4 weeks or 3 months, and I think obviously you mentioned about 3 months being a sensible thing for things just to stabilize down and make sure patients keep it on the statin regularly. So 3 months makes more sense.
It was in the earlier slides that we shared, which we said ideally no less than 4 weeks. That's if the patient started and took it, religiously. But there's always going to be an adjustment period. So I think 3 months is more the pragmatic way, just to ensure that there is no doubt about that, as we discussed earlier on. Okay, good. So the next thing I'm probably going to hand over to Stuart to talk about, but there's a nice box at the back of the national pathway about monitoring, and in addition to the full lipid profile, we recommend, and the thyroid function, we recommend the checking of liver profile as baseline, and in particular, of course, the transaminases. I'm going to let Stuart detail about that, but this box at the back is what recommend what kind of tests you should do in primary prevention, second prevention, baseline, 3 months, 6 to 9 months, 12 months, and yearly. I think practices have changed slightly, and it also says there about what to do if there is elevation in the transaminases. Is right at the back. You can read that. It's very obvious and very clear. It doesn't need to be kind of elaborate. I'll hand over to you, Stuart. I've got your slides here.
Thanks, thanks, Rani. Yeah, so it was just to illustrate a couple of and this is one case actually of illustrating abnormalities with liver function tests, which could give a subsequent disturbance in cholesterol, and that's been mentioned as a secondary cause. There's 2 reasons for doing this. Obviously, liver function test at baseline could give you an idea of something else going wrong and causing high cholesterol, but it could also give you it gives you a baseline. So if you are subsequently starting treatments, you know where you're starting from, especially if you've got pre-existing fatty liver disease or something giving you a higher ALT, and then you're wondering, was the ALT what was the ALT at baseline as well? So it makes a lot of sense. So the only time I really do full liver function tests, and by liver function tests you're looking at this is a typical profiles will probably be bilirubin. Albumin tends to be in there as well. Albumin's mentioned in the national pathway there as well, because if albumin is low, then it could point to something like nephrotic syndrome. But here I've just illustrated some of the liver function tests related to particularly disturbed, and this was an elderly patient who had jaundice, visible jaundice, with the bilirubin being 384 there. Alk Phos was raised. ALT was raised slightly, but in context of the bilirubin, the Alk Phos, the rise wasn't quite as significant, and the gamma GT was up there as well. Now the cholesterol was measured at the same time. We thought this was a pathology related to gallstones due to pain as well being present, and you can see the cholesterol here is markedly high, 12.4, triglycerides 2.4, HDL 0.8, and non-HDL 11.6. Now, the other thing that we're finding is, especially with people now doing searches on their system retrospectively for conditions like familial hypercholesterolemia, when you're going into systems like EMIS and System 1 and you're pulling out the highest cholesterol, sometimes these values, like a 12.4, will be pulled out, and you might think, is this high cholesterol? Now, subsequently, Rani, just click on the next slide, actually. In this patient, you've got to be careful to say, actually, was the 12.6 related to a pathology at the time, or was it a true representation of a primary hypercholesterolemia? So there's an illustration just before there. Some of the other pathologies, obviously, gallstones could be one of these. You can also get things like primary biliary. It used to be called primary cirrhosis, now called primary biliary cholangitis. And primary sclerosing cholangitis, which gives a little diagram there that affects the clearance of bile from the liver, and it doesn't allow cholesterol loss into the GI tract and loss through that way. They get reflux of the cholesterol back into the blood system, giving you higher cholesterols. Now, whether this actually causes atherosclerosis is another question, but what we do know is it can give a higher cholesterol. So just on the next slide there, Rani, there's this the picture of the cholesterol there at follow-up. Now, the liver function test is still slightly abnormal there, with the bilirubin it's come down a bit, but it's still high. It shows the cholesterol is almost halved, and it shows you an illustration of the effect of having an obstruction essentially to your biliary flow. So if you're looking back at these patients' results in System 1 or EMIS, you might think, actually, has this patient got a familial hypercholesterolemia pattern? But you've then seen a subsequent pattern where the cholesterol's come down a lot. So it's worthwhile double checking to see if there's anything coded in the patient's history to say, have they got any liver abnormality at that time as well. So again, just an illustration there of the magnitude of what could happen when you get kind of obstructive pattern in the liver sort of bile outflow there. Thanks, Rani. I think is that. Yeah, and my next point was just about the illustrating there about so for follow-up for these patients, I'm very keen on not requesting lots of tests. So I never ever tick the LFT box or tick LFTs. I never do that for patients who are monitored on statins unless they've got some baseline abnormality that we're following. I only just check ALT is a standard one. ALT is probably more specific for liver. AST, you can get muscle effects as well to a greater or less extent. I think most labs would probably be ALT would be the default, but I'd encourage people just to be targeting there, not to do a full liver function profile when you don't need it, because you may find some random abnormality that you're not too sure what's going on. But if you're ticking ALT there at that 3 months and then a year, and then if their values are okay at that stage, then we don't need to do annual ALT monitoring thereafter, unless there's a problem with the patient or there's something else that happens. So it just minimizes the testing, because I'm all aware that everyone gets lots of results coming into them these days as well. So it just targets where we're most likely to get a disturbance if after initiation or titrating, changing a dose of a statin.
Okay. I think that probably brings us to the end of our talk. So that leaves us with just about under 7 minutes for any questions that you guys might have. Let me just stop sharing. And
so Rani, there is one in there. I just mentioned I would go back to it in the chat there. Just further up, I think when you were discussing around the calculations at the start of the presentation there, it says for most part we're starting cholesterol based on the Q risk, or maybe that's cholesterol lowering therapies and the Q risk, which whilst lipids impact, many other factors contribute. How much of a change can it make in years, RE time to start, based on these invalidations? How far wrong can we actually go if we miss these things? So I don't know if that's alluding to the calculations around the invalidations around the Friedwald calculation. I mean, obviously, Q-risk is using non-HDL total
Yes.
cholesterol ratio, so you're actually not involving the you know, you're going back to your original non-fasting point. You know, ultimately, if these patients don't have a cholesterol above 7.5, or you're not thinking of you know, general population, most of them may not need a fasting if it's a lower value. You can get your total cholesterol and your Q-risk, and they don't have a high triglyceride. So it might not
I mean,
impact.
yeah, I mean, in a general point about the benefits, and you are correcting many other factors, you can always go back to the risk calculator and look at, I mean, one thing I used to like about the GBS3 risk calculator, which I think is a bit down at the moment because they're updating it, because it used to show you how much of additional benefit you're going to get, you know, over lifetime as well as the 10 years. And also you can check the modification of other risk factors. I mean, for primary prevention, of course, for the Q risk, it's a discussion that you want to have with the patient and just see what the additional benefits. I understand what you're saying about the difference, but you are using a ratio, as Stuart was saying. So you're not inputting an LDL value for the Q risk, you're inputting a ratio. From my understanding from the lipid world is that the ratio aspect is not as accurate in reflecting association with atherosclerotic disease as probably we're not as big fond of ratios as we used to be nowadays. So maybe that is something to consider in the risk calculators. I mean, sometimes what I did with my patients is I did use other risk calculators. I mean, there is the ESC score risk and JBS3, and it had a little bit of additional nice diagrams and illustrations, which I found them useful. You may want to consider them, but I think Stuart answered that point as well. Anything else?
There was also a question earlier about HRT on TG.
Hang on,
What about HRT on TG? It was asked at 12:15.
Like effect on triglycerides.
I think so.
I mean, there's a whole debate about HRT and its use. I think, and the effect on lipid profile generally, and that like HRT and decrease in LDL and effect on LDL, increase in triglycerides. But I'm not sure if the level of increase is actually atherogenic. So I think it's something to be debated if actually the levels of triglycerides that you're going to get is significant enough to be atherogenic. It's not something that I've looked into recently, Stuart, but from memory, it was all debate around, you know, the effect of HRT on lipid profile generally and association with atherogenicity, which I thought wasn't really a concern as far as I remember.
Yeah, I mean, we do see, if you flip it around, we do see in postmenopausal females, not in HRT, we see a slight rise in cholesterol. That's something that you do see across you know, across the board. My approach with HRT is it's not something you would. I mean, it's not a significant bearing on the lipids, I would say, in general terms, and you wouldn't really you wouldn't advocate HRT initiation for a cholesterol reason. In terms of that, there's obviously a whole risk benefit discussion around HRT, but really lipids wouldn't really come into that. And so yeah, I think it's kind of overall minimal. That there are other more significant contributory factors. And you mentioned some of the things: obesity, lifestyle, you know, diet, sugar control, all those things that are probably having more of a bearing than that. The kind of hormone supplementation.
Thanks. The use of statins in Somebody's. Oh, you replied to that, Stuart. Sorry. No difference between patients without Gilbert's should have an LFT derangement. You've already answered that. There is a question there about. Let me just see. If somebody has raised TSH as well as raised cholesterol, well, it depends the primary secondary prevention, I guess. If it's secondary prevention, we know that patients benefit from statins for secondary prevention, but for primary prevention, I would probably correct TSH first before actually going into giving somebody a statin. So I would remember we said we need to explore secondary causes first and exclude them. So if you identify a secondary cause, ideally, you need to correct that before you actually move on. Non-HDL cholesterol ratio comes up in full lipid profile. What is its significance? We don't. It's something that we historically reported the ratio, aren't we? But I think it is falling out of fashion in the lipid world because the association between it and atherosclerosis is not as important as it used to be. So it's something that we used to rely on a bit more before. Maybe Stuart can add something about that. This is what I know.
So it's just curious. It's just for curious to allow people to put it into curious. A lot of systems now pull that out. I know although EMIS, I think there's a curious just removed from it recently as well. I mean, I think because we're dealing with population here, then a lot of the traditional population statistics came from that. Obviously, as Rani says, you've got two measurements in the ratio, and both of them are subject to error. So you multiply your error up. But in general terms, it's a finger in the wind. It gives you a finger in the wind in terms of where direction's going in terms of that risk calculation. So that's why it's in there. So to allow you to stick it into the curious calculator or the calculator you're using.
The slide about the monitoring is on the National Lipid Pathway. It's just basically it's at the back of the National Lipid Pathway. If you download the National Lipid Pathway, I'll put a link soon. It's all in there. There's nothing that I put that is not on there. Okay, I'm conscious of the time. We're out of time. Is there any other burning question that we need to address?
Rani, if we could just answer one more, sorry, from an attendee that sent through it earlier in the week. About I've had a patient recently with raised cholesterol. Prior to recent lipid profile, he fasted for 48 hours. He thought this was responsible for the increase in cholesterol compared to previous total cholesterol from 7.4 to 10 over 6 months, and LDL 6.1 to 7.7. So is prolonged fasting related to increasing cholesterol levels?
I wouldn't think so. I don't think it is. I don't know what Stuart thinks, but in my opinion, whether you fasted 24 hours or fasted less, I think it's usually 8 to 12 hours we recommend. But if somebody fasted longer, that their total cholesterol would go up. Is not something that I've come across or could think of. What do you think, Stuart?
Yeah, it's a bit odd. 48 hours it's a bit of an odd time period. What we in is there certain diets. One, for instance, is the ketotic diet where people are having actually quite a high, they're cutting out carbs completely and they're on a high saturated fat diet. That can put cholesterol into double figures. Yes. And we have seen that before. 48-hour fasting is probably not very good for you, but I don't think it would skew your cholesterol that much, is my understanding.
Yeah. Right, I think we need to wrap up because we finished 2 minutes over.
I can answer any questions that are left on the chat later on. I'll just put it in the team thing. If there's any questions, I can happy to answer those.
Thank you so much, Stuart. Thanks, everybody. I think Jess put some feedback form there, so we'll be grateful if you can complete. Jess, shall I hand over to you to wrap up? Thank you very much for all those who joined us.
Thank you very much, Stuart and Rani, for today. If you have any questions, again, as Stuart said, please either message myself and I can transfer them across. If you could please also fill out the webinar feedback form. I've put the link in the chat. We'd really appreciate it. It really helps us form future events as well. So just thank you very much for attending today. And hopefully see you soon at another webinar. Thank you all.
Thank you so much.
Thank you.
Thank you.